pictures on those other ones, you'll see a flow meter on them, okay? This one's built in. So high flow, I would just say if you want to like think of it as real easy, probably anything bigger than 1 flow meter, okay?
Anything bigger than what?
Anything higher than 1 flow meter could be considered high flow, okay? The real, yeah, well, like what I mean is 1 flow meter goes up to 15 liters per minute.
Anything above that would be considered. So basically anything above that would be considered high flow.
Yeah, but ultimately it's going to come down to your patient because, right, like in the NICU at Children's, we would usually set our high flow babies at 6 liters per minute. They would stay there, okay? We would never go higher, we would never go lower. We would just 6 liters and that's all, okay? Now, an adult might need 60 liters, okay? So it's really going to depend on the presentation of the patient that's there, okay? But what I want you guys to kind of just feel some of these differences, okay? So, put your hand out just to feel that. This is 5 liters, okay? Nothing crazy. Okay, now that, I mean, it shouldn't be anything crazy, right? Because you guys know your normal cannulas go, what are you, the highest you set that at?
10, 15, 12.
I know it starts at about 0.25.
So,
The nasal
the
cannula?
nasal
A
cannula,
quarter to 6.
6. Okay, so this is 5. So, right, this shouldn't be a big deal, okay? So, now let's change it to something a little different. So now for this one.
Ooh, that feels good.
You can hear it too.
Okay, so now with that in mind, right, that's a lot higher, right? What's the, if you're gonna throw a term out, what would the term be that you're feeling right now? What do you feel against your hand?
Pressure.
Pressure, okay? So, the higher the flow, the more the pressure, okay? Now, we're gonna stop there for a second, I'm gonna turn this off, turn it down a little. Okay, so if you guys are recording, it's cool, but it's going to be more of a like a little writing section just to kind of understand some stuff. So we said that you feel a pressure, right? That pressure is going to come into play with the therapy. So there's 2 terms that you guys have, well the last group said you learned one of these, okay? The 2 terms that we got to focus on their ideas right now is PEEP and CPAP. So did you guys, the PEEP was the term that they said they learned.
Is that peak or peak?
PEEP, P-E-E-P. So positive end expiratory pressure. So what is that? Where are we measuring the pressure?
On the left.
On the expiratory side, where? Think of it if the expiratory started here and ended here, where would we be measuring the pressure at? The end, right? So think of it when you exhale, at the end of exhalation, that's where we're going to measure this pressure. Okay?
Is it at the end of exhale?
At the end of exhalation, okay? And that's how, again, kind of just break down what the word means, and hopefully that can kind of help pinpoint where we're talking about too. So positive end expiratory pressure. Okay, so
Positive what you said? This is a positive pressure machine, no? That's what it's...
well, we're kind of going to get into that right now, okay? So positive end expiratory pressure, and then the second term was CPAP, and that's going to be CPAP, and that's going to be again continuous positive airway pressure. The bigger idea for both of these is that this is the pressure, I'm going to say that it's called baseline pressure. Baseline pressure, okay?
Baseline?
Yeah, baseline pressure. And so basically what we're saying is that your pressure should never go below this, okay? Because
Go
this-
below what?
the baseline pressure, whatever you have that set. a real common number for both of these is 5. 5 centimeters of water pressure is a real common starting point.
5 centimeters of pressure.
5 centimeters of water pressure.
For 5 centimeters.
Yeah, so like you guys have to like millimeters of mercury, you're gonna start writing that a lot. Centimeters of water pressure, you're gonna start writing that a lot. Milliliters, liters per minute, you're gonna start seeing all that, okay? So, higher the flow, higher the pressure, okay?
Is there a rate at which you increase that? So like for every, is there like some kind of system to that? Like for every X amount of flow you increase, the pressure goes up by this much?
There is, it's not great science. It's not great science, okay? We'll look it up in a second. But what you're gonna hear with this is that it provides a CPAP or a PEEP-like effect, okay? The high flow does that. So now, I'm hoping your question is, well, what the heck is that effect, right? Or why is that good for the patient?
Provides a what effect?
A CPAP or PEEP-like effect. And so, yeah. So, what we use PEEP for, CPAP, is we're trying to open up the lungs, okay? And so, essentially, what we're trying to say is we're giving more flow, and we're trying to open up the lungs, which is called recruitment. We're recruiting the lung. And then with more lung units available, it should have better gas exchange. Okay, now this is going to be you're going to hear these terms again.
When you say that when more lung units available, you're talking about just like opening up like the
Alveoli. Okay, now when we do a mechanical ventilator, and the easiest way to think about this is just think if your patient's on a vent, they're not breathing. That's not true. But just to make it black and white for you guys to start learning. If you're on a vent, just think that they're not breathing. Okay? We use the word PEEP when a patient's on a vent. Okay? If a patient's spontaneously breathing on their own, then we would say CPAP because that's a spontaneously breathing device.
So when a patient is breathing on a ventilator, we could say is CPAP?
No, PEEP is the term for the ventilator.
Okay.
But CPAP, they're like the same thing. It's just on your
They're breathing on their own, you said?
CPAP, they're breathing on their own.
Not without the machine.
The mechanical ventilator, think about it as they're not breathing on their own. Okay, and now, again, the idea behind those two terms, right, or that therapy, is to open up the lungs, promote better gas exchange. So, they say that the high flow system provides a CPAP or PEEP-like effect. It's trying to do the same thing, but we can't say, like to Emmanuel's question, there's not good science behind this, because what do you think changes as far as the pressure when I'm breathing with my mouth closed compared to open?
Less pressure.
Yeah, right? And so anytime I open the mouth, you're going to lose some of that PEEP-like effect. The other thing is too that this is not a CPAP device. Like if you had a nasal, like I'm thinking NICU, we have nasal cannulas that are designed to occlude the nerves. These are not designed to do that. You don't want these to fill up the nose where it's pushing out on the nostril, right? Because you're going to have to worry about pressure ulcers and things like that. So that's another reason that we know we can't say it's a true PEEP or a true CPAP because we know they're losing pressure places. And so again, when they did the research on this, it's very hard to measure accurate stuff. But there is kind of a system. I think it's like, this is only for like starting it on someone. But I think in the ER setting, I want to say it's like 2 liters per minute per kilogram, like up to like, I want to say like 20 kilos. And then it's 1 liter after that. And so it's just, like I'm saying, it's not exact science, but what you'll hear a lot of RTs say is we're going to start high and we're going to titrate down. Okay? And So try 20, right? Or try 40, and then see how they do.
Would it always be weight-based or only in a pediatric setting?
I think that was adult setting actually.
Oh.
Yeah. But that again, the research, that's like kind of the best we have right now. Now I know at Children's, this will be once are you guys going to Children's? So you could ask your preceptor to look up the high flow. There is a weaning protocol because my friend is the clinical specialist there, and she developed it, so I know that's there. So there is a way to turn this down based off of evidence. Okay, but going up, I'm not sure. It might be in that protocol too. So leaders, right? We can deliver a pressure. That's going to help open up our lungs. We usually say that we're going to modify the leader flow to help with the patient's work of breathing. Okay. So if the patient's huffing and puffing, we're going to try going up to, as high as we can, right, where it relieves it. If you're getting up to the maxed out settings though, maybe a vent is a better option. Maybe a BiPAP is a better option at that point, right? So that's the thing that your managers, right, and your charges and stuff, that's what they worry about is that we're just, as clinicians, we don't want you guys to just mask something, right? Like trying to put a Band-Aid on it. So yes, you're going to have to deliver those for the time being, but you should be thinking ahead, and anticipating what happens next if this isn't working. Okay. So, because what is this one right here?
Oxygen.
That's your FiO2, your oxygen level, okay? And so this can mask a lot of things, right? Because if we just pump them up, their SpO2 should go up, right? And so we want to make sure we're not masking things, that we're actually really helping the patient through it, okay? So again, clinical judgment, talking to your preceptors, getting that bedside experience, that's going to all help you guys make this click a little bit easier. Okay, so with leader flow, the last thing why I grabbed this thing earlier, there's another bigger concept here that the leader flow helps. So I still classify this as an oxygenation device, right? So your non-rebreather doesn't work, go to your high flow, right? Or that would be like the next step up. And then after that, CPAP or BiPAP or the vent, okay? But now with your, can I get a volunteer to just push the silence button? Okay. So, the other thing that this does, okay, is, and we're going to talk about this next semester in physiology, but do you guys remember this term for the gas that's from the nares all the way down till about the, I don't know, the terminal bronchial? You guys remember what that area is called? So,
Just like the upper airway?
upper airway. So those are conducting airways. Okay? Conducting airways.
Conducting airways.
Now,
You just
broke it.
like stop.
Now you just click it once because you're turning off the alarm. You click it the second one. Go to the silence button. So do it once and then see this. Okay, we got about 30 seconds. So that's an airway. It has gas in it. Gas is not participating in gas exchange. Do you guys remember a term for that? Gas that's not participating in gas exchange. Okay, so we call this dead space.
Oh yes,
Okay, that's the exact same thing with velocity. So dead space is wasted gas, okay, or gas that's been used already. So we have a normal amount that we always have, right? Because this conducting airway always has gas in it. And so we're okay with that, right? But now think if you get sick, you have impaired gas exchange on top of that, you're going to be rebreathing CO2, okay? And so the other way that this helps, right, is we put this on, can't reach it, right? This is here, and it's shooting that 40 liters, right? I don't know if this actually works or not. Probably not, because it's not a big deal, but what this is trying to do is, if you put your hand right here a little bit, you feel the flow, but it's washing all of that dead space out. So now, instead of every breath your patient takes, right, it's got that CO2 that's in it, now it's pure oxygen, it's pure the conditioned gas that you're delivering. So this can help with ventilation issues, but I would still classify it more as an oxygenation device. So washing out that dead space really helps where every breath they take in, now they're getting pure, fresh oxygen. Okay?
Is the air that comes out of there, is it humidified?
Yes. And so that's going to be the next thing. So leader flow, right? So that helps a little bit with ventilation. It's going to help with deeper breathing. It's going to provide some of that positive pressure, that PEEP-like effect, so we can oxygenate a little bit better, hopefully as well. We also have, right, the easy, quick and easy fixed oxygenation issues, FiO2. Okay, so that's all pretty straightforward, right? We're low on oxygen, turn it up, right? Now, what's the magic cutoff number for when you start having problems with oxygen?
Magic.
Yeah, so there's things like oxygen toxicity.
150 mmHg was the mercury. That's the
That's
pressure.
a PaO2, okay, pressure, yes. But we usually say 60% or more is starting to be hazardous to your patient because oxygen toxicity, and then also you start washing out that nitrogen and you get absorption atelectasis. Okay, just meaning that, yeah, this is gonna get crazy next semester. So, right, the nitrogen that is in room air applies a very big pressure in the alveoli. So once we start washing that out, because we're delivering 40 liters, 100% oxygen, right? You don't have that big pressure keeping the alveoli open. You just have oxygen in there now, which does apply pressure, it's like 150 or something, right? But nitrogen's like 500-600. So
Is that going to 760 also?
that's barometric pressure. Okay, so but in alveoli right now you have no nitrogen. What's happening with that oxygen that's in there too? Where's that oxygen supposed to be going?
Your lungs, your heart.
Well, it's in the alveoli already. So where's it go after that? Where?
To the body?
The atmosphere.
No, you're breathing in at this point.
Oh, okay.
So it's the gas exchange so it goes
It's in
through
your
your
lungs.
blood, and then it goes through your blood.
Your capillary system, right? So that oxygen, right, that you're hoping keeps the alveoli open is actually getting absorbed. So that's why those areas are more likely to collapse. Okay, so that's why we don't like high amounts of FiO2. Okay, so magic number
have pressure
60%. Okay, if you hit 60, then I would start playing around with going up on the flow. Okay, now
You hit 60% on the,
on any device.
on like your
For
FiO2?
oxygen,
Or-
right? Or FiO2.
FiO2 and oxygen, that's what we're talking about. Okay, so it'll be a button or a knob.
60% for both.
Mhm, yeah. So if you give your patient 60% oxygen, you're gonna start causing problems. Now, in real life, you're gonna see patients maxed out and stuff. It's just gonna happen. We're doing the best we can. So why you need to remember that number is for your testing purposes, because basically, like what the NBRC is trying to get you to realize is that you know, right, you learned in school that high oxygen, 60% or more, does these things.
But
So-
isn't there like one of the
so
devices?
why would we want to hurt our patient?
We wouldn't.
You wouldn't, right? If you're being a safe therapist, you wouldn't. If you're gonna say keep going up on FiO2, right, when there's other options, then they're gonna say you missed that point, right? And if you miss points, you don't have to on too. So what were you saying?
Oh yeah. Why is the non-rebreather? Isn't that one like 60 to 80%?
So yes, and that's an emergency situation, right?
Okay.
And so again, you can go up to 100, right? But is it like, again, thinking ahead, where do I go from there? Right? Like if I'm already at 100 here and 40 liters,
Oh yeah.
right? And a non-rebreather is kind of the same idea, right? We throw it on first because we want to see if it fixes the problem
Quickly.
quickly, right? And if it doesn't, well, then maybe we need one,
And then we need
right? So, but you have, that's kind of like what you need to take away from this is 60% is a very important number for you guys to remember. Higher is bad. And so the options in your answers, right, from your testing, like multiple choice tests, right, if it's above 60, right, you gotta make sure that's the best option out of all the other ones. So if there's something else, because you know you're hurting the patient, right? And your MDRC hospital says that if you hurt the patient, you're not doing what an RT should be doing. So just remember 60%, okay?
Is there a way to measure like FiO2 on there? 'Cause that's SpO2, right?
No, this is FiO2.
FiO2,
Yeah.
okay.
SpO2 only comes from what?
The fat.
Your pulse ox, okay? So this is what we're giving, right? We're giving this to the patient. Okay, the monitors and things like that are going to have exactly what the patient gets, what the patient's power to react. So, last thing here, okay? Now this is the other thing that I say is really important. So you can do oxygen therapy. You can increase the liters, right? And we talked about how liter flow can help with the breathing and ventilation. So now, what is this temperature thing? What's that talking about?
The temperature of the air that's being put out.
Temperature of the water in there?
Yeah, so we're gonna, this, again, everything's built in, so you have a heater and humidifier in here. If you look on yours, let me try to pull mine up real fast, that we Googled. So here's the heater for this system. I know you've probably seen these for sure. Okay, so basically, that's the heated, humidified portion of it. And that heated, humidified idea is big because, again, going back to this, there's going to be some fancy terminology somewhere. I'm just going to do this. Somewhere around this area, there's something called your isothermic barrier. Okay, and basically, it's saying that your body has this much space and time to get the air you're breathing in 100% saturated with water vapor and up to body temperature. Okay? And okay? And so normally your body can do that, right? It starts filtering, it starts humidifying, it starts warming, right? And once it gets past there, it's ready to go in the lungs. Okay? But now when you're sick, things change. This boundary goes up, you have less time, and then your body also might not be working as well either, right? You might have secretions in the way of things, things like that. So warm humidified air conditions the gas for the patient, right? Because when we think about this at a metabolic level, all of that stuff to get that gas ready to enter the lungs is taking up energy. Okay? And so when we think of our critically ill patient, we don't want them doing that. That's bad, right? So we want to help them as much as we can. So we're going to humidify and condition the gas for them before it gets to the patient. And that's why the heater and humidifier is important. So conditions the gas, that's one. It conditions the airways, right? It keeps them nice and moist. When you have that rapid breathing pattern, right, it's a lot of dry gas, right? And you're huffing and puffing, you're not filtering it, you're not doing any of that jazz, right? So it can make your airways get inflamed, it can make your airways dry out. That's gonna cause more problems. So if you give warm humidified air, you don't have to worry about that. And so, what are those little hair things called in your airways? Cilia, right? It helps those work right, conditions that environment for them. So the humidity is a big thing with the high flow as well, okay? And so conditions gas, conditions the airways, and then it doesn't allow the body to work so hard, okay? So
Conditions the airways by what? What did you say?
providing them moisture, keeping them nice and moist. So your high flow, and again, if you look at some of those ones you Google, they can be very simple looking things, right? But you are doing a lot of different types of really beneficial things for them, okay? So liter flow, FiO2, humidity, okay? And so you touched on all of them, okay, why they're important. Now you just keep building off of that, okay? And again, in real life, you're probably gonna see patients above that 60% range because they're usually not stable, and we're trying to stabilize them. But one of the first things that everyone's going to do on the healthcare team is try to get that down as soon as we can. Okay. Questions on anything?
Nope.
Okay, good job, guys. I know it's a lot.
Thank you.